Good evening, Dr. Diana. Can we start the program?
Yeah. Can I start? Am I audible?
Yes, Doctor, you are audible.
Yeah.
Okay, so hello everyone, and it's my honor to welcome you all to this webinar. I'm Dr. Diana and I'm your moderator for the day. I thank everyone for taking the time to join us today. This webinar is definitely going to be worth your time. This webinar is hosted by GHA, Global Healthcare Academy. Global Healthcare Academy has been instituted with the mission to develop complete and compromised human resources for the healthcare sector. GHA also promotes innovative solutions and enterprises in healthcare. Their core purpose is to bridge the skill and knowledge gap between formal education and needs in the healthcare industry. The distinguishing feature of GHA training includes the following: intense collaboration at every stage between practitioners and tutors, from conception and formulation of training programs, enlisting of faculty with sufficient work experience, case-based learning from real-life situations, and practical-oriented learning methodologies. GHA is led, managed, and advised by reputed doctors and healthcare professionals. The topic for today's webinar is Approaches to Skull-Based Surgery by Dr. Gaurav Medikeri. Dr. Gaurav Medikeri is an esteemed surgical oncology consultant based in Bangalore. With a solid academic background, he holds an MBBS degree along with Masters in ENT, where he achieved a remarkable distinction of being a gold medalist in the state of Karnataka. Dr. Gaurav's expertise lies in the field of rhinology, anterior skull-based surgery, serving as his primary and secondary interest, respectively. He received his fellowship training in rhinoplasty and facial cosmetic surgery from a reputed institute in Seoul, South Korea. He has received extensive training at renowned international centers, including a fellowship recognized by the Royal College of Surgeons, training at of Surgeons of England, and also a fellowship from St. Paul's Hospital in Canada, approved by the University of British Columbia. Driven by his passion for advancing medical knowledge, he has made notable contributions to the field through his publications, including his recent involvement in the International Consensus Statement in Rhinology, making him the first Indian ever to contribute to this prestigious international guideline document. As an avid researcher, Dr. Gaurav actively engages in various research projects. Above all, he is known for his compassion and dedication to his patients, striving to provide a positive hospital experience for each individual he serves. Dr. Gaurav Medikeri, we are very fortunate to have you. Over to you.
Thank you so much, Diana. So, Vignesh, are we good to, can I share my screen, please?
Yes, Doctor.
So, can you all see my screen? Hello?
Yeah.
Yeah, okay.
We can see your screen.
Okay, so I've not done a test today to just assess whether or not the videos are going to work well, but I hope I'm actually sitting a little bit in a remote location, so I hope that my internet speed is good enough to support these videos. So let's just start this topic. So rather than talk about approaches to skull base, yeah, I mean, we are going to talk about approaches definitely. But I would also like to talk to you about some of the challenges that we face when we are operating, skull-based surgery cases. So, the most common thing, the whole skull base is basically divided into anterior, middle, and posterior. So, in the anterior skull base and the mid skull base is where majority of our endoscopic procedures do lie. Having said that, just recently I also did a spinal tumor, which was done transnasally, but I did it transoral by splitting the prevertebral muscles and then removing the tumor from there. But that also can be completely done, endoscopically these days. So, Vignesh, can you just take charge of admitting people who are entering the talk, please, so that I can focus on the lecture. So let us just move to our first case. So I want to show you, the first case that I want to talk to you about is basically a pituitary surgery. So pituitary surgeries basically for a skull based surgeon would be similar to what tonsillectomy would be to an ENT surgeon, or cataract surgery would be to an ophthalmologist, right? It's one of the most common surgeries that you're going to get. So the cellular tumors is what skull-based surgery basically evolved with, right? So here I'm going to show you a case. This is a really funny case, actually. So this is actually an autoimmune pseudotumor, right, in a patient. So what I want you to appreciate is that here you have the middle turbinate that I'm touching there. So this lady, actually, she's had sinus surgery done before, and that is one of the reasons why you saw that there was so much bleeding that was happening. So the reason why she had a sinus surgery done is because she had headaches, okay? And those headaches were just not going away even after the sinus surgery. So I got a MRI brain done, and lo and behold, she had a cellular mass. So effectively speaking, the patient's sinus surgery was actually sort of a waste, because when I compare her old scans, right, she did not have any sinus disease to begin with. So it's quite unfortunate that she had to undergo this sinus surgery for no reason. But the actual pathology was behind the sinus in the cellar. So once I did a complete ethmoidectomy here, and you can see that I'm actually opening the sphenoid. So the thing is, the sinus surgery was also not a complete sinus surgery which was done. So that is the sphenoid that is being opened there, and I'm drilling out the walls of the sphenoid here. So I'm making sure that I keep some merocell. The reason being that I want to preserve the nasopalatine branch of the sphenopalatine artery, which actually supplies my Hadad flap. So I'm trying to get as much adequate decongestion as possible, but I'm also being very cautious here. I'm making a small incision on the septum. This is to sort of delineate my Hadad, right? My rescue Hadad, rather. I'm not going to raise the flap entirely, but at the same time, should I have a CSF leak when I'm operating, then I would like to have a Hadad on standby. So I just did a rescue Hadad there. And that is the keel or the rostrum of the sphenoid that you're seeing there, which is projecting in the midline. So I've drilled the posterior septal bone, that is the vomer has been drilled out completely. And I'm sort of extending that posteriorly onto the keel of the sphenoid. So there are multiple ways of doing this, the osteotomy. So this is called either shoulder osteotomy, or you can use a drill. So if you're using a drill, make sure that you don't go far laterally, because you don't want to sort of injure any of the important structures which are present laterally. So I've reached the cella. So this was not a very pneumatized cella here. You can see that the cella is actually very poorly pneumatized, and that was causing me quite a bit of, I had to do quite a bit of drilling to reach there. Also, the sphenoid body was not very, well defined in this case, which made it a little difficult for me to reach the cella. So in such cases, there's one point that I want to mention here is, if you want, one of the tips for beginners would be to leave a little bit of the keel behind so that you know where the midline is. If you stick to the midline, then your chances of causing a vascular injury become very low. So there is something called as intercarotid distance. So if any of you read the papers which have been written by Albert Rotten, you'll know that this is called as ICD, that is intercarotid distance, is actually something that you need to calculate when you're reading your DICOM images. So there have been studies where Albert Rotten's mentioned that ICD, that is intercarotid distance, can be as low as 6 millimeters, and it can go up to around 2.4 centimeters also. So once you know your intercarotid distance, then you know how much of the midline you should stick to so that you can avoid any vascular injuries. So that is one tip that you can take from today's lecture. The first step would be measure the intercarotid distance whenever you're doing any kind of skull base surgery. So that gives you an idea of how much leeway you have or how much of a playground you have, so that you don't cross that luxurious distance that you have between the two carotids, and then that way you're remaining in the midline and staying safe and preventing yourself from having any injuries. So so this is basically a stellar shaped dural incision that I've made. So the reason why I prefer this incision is that you can reach all the four corners of the sella in this incision. Now, normally what would happen here is you would have had significant amount of the tumor already popping out. If this was a normal pituitary tumor, you would have had a good amount of tumor already popping out, which you would have taken for biopsy and then proceeded to clear the rest of the tumor, either by using 2 suctions, or this is one of the techniques that has never failed me. So what I call this technique is soft dissection and volume displacement. So you can see I'm using a Merocell piece. This is without adrenaline, mind you. The minute you cross dura, you have to go without adrenaline. So I'm sort of displacing the tumor from the walls. That is the anterior wall, inferior wall, anterior inferior recess, lateral wall. So the lateral wall of the sella is actually the medial wall of the cavernous sinus, which is a single layer of dura. That is why there is a lot of infiltration of the cavernous sinus whenever there's a sellar tumor. So I'm pushing this Merocell into the lateral recess, thereby pushing the tumor into the nasal cavity. So this is called as volume displacement. So that way, I am not touching any critical structure like the cavernous sinus or the carotid artery here, because there is interposition between my instrument and the cavernous sinus by means of this Merocell piece. So this Merocell piece also occupies a certain amount of volume, which is basically what the exact amount of tumor which will be displaced by this Merocell. So here you can see now that the area of the inferolateral recess is actually completely cleared of tumor here. And you can actually start to see the lateral wall of this sellar space, pituitary space, that is the cavernous sinus also here laterally. So this tells you that you've completely cleared the tumor from this area. So always clear the tumor from below and then go upwards, because the minute you start clearing tumor from above, your pia and the dural layers will actually drop down, making it difficult for you to actually clear the tumor in its entirety. So now you can see that there is no tumor left. So the special thing about this case was this was an extremely fibrous tumor. In fact, you can see that this is not looking like a normal tumor at all. So whatever you're seeing, which is in red here, this reddish tissue that you're seeing is actually normal pituitary gland. And this has to be identified by you before you start the surgery on your MRI scan itself. So this reddish tissue which you're seeing here in the middle where the suction just touched is actually the normal pituitary gland. So you can see whatever you can see here between 3 o'clock to 6 o'clock is all tumor, and this tumor has to be completely dissected out. And I'm doing the same technique on the right side here. This is called as soft dissection and volume displacement. So I've taken all of this for biopsy. I can see that tumor is completely resected out. That is what pulsations you're seeing from above is the dura, but whatever pulsations you're seeing on the right side is actually from the cavernous carotid artery. Okay, so make sure you remove the tumor completely. Here once we identified, so we got a frozen section done on this immediately, and we found out that this was actually a IgG4 tumor, and that is the reason why there is no need to be very aggressive with your tumor resection here, because this is not a real tumor. This is a pseudo tumor. It's an autoimmune condition. So if you put this patient on cyclosporin or methotrexate or steroids, this is going to regress completely. This is more to do with a patient's immunological profile rather than being a tumor. So whatever bit of tumor which is adherent to the pituitary, there was no need to be aggressive to remove it. So I just removed how much ever was possible, and I didn't want to damage the normal pituitary, because if you do, then the patient's going to have panhypopituitarism for the rest of her life. That means that she will be spending at least around 27 to 30,000 rupees per month just to take hormones, and that is not worth it in a condition like this. Not to mention that she's going to be on cyclosporin or methotrexate also. So this is how you can actually do a complete tumor resection, even if the tumor is actually quite fibrous, right? So this was the first challenge that I wanted you to understand. Now, there is a new technique of surgery which is called as transorbital neuroendoscopic surgery. There's very few people all over the world doing this. So I happened to meet two Italian surgeons also who are working with Paulo Castronovo very recently, who are very keen, and they are also in their beginning, steps of doing this type of surgery. So the lady who started this surgery was actually one person called as Dadine Doob, who's in South Africa. Huge regard for her. I will show you my experience with transorbital neuroendoscopic surgery. So the first case I want to talk to you about is this girl who fell from a height of, she fell from the second floor of her house and she landed on her head and she had a fracture in the orbital plate of the frontal bone. As you can see here, so you can see that there is a meningoencephalocele which has developed in the orbital plate of the frontal bone. And this eye, the patient's left eye, was constantly bobbing. That was because the pulsations of the brain were being transmitted through the eyeball. And she also had a CSF leak, which was through the nose, but this CSF leak was happening through the orbital plate of the frontal bone. So that means that the CSF pathway was from the, you can see the CSF here, which is getting collected here. This is because the pathway being followed is from the brain to the orbit, and from there through the lamina papyracea into the ethmoid sinus, and from there it was dripping into the maxillary sinus and then coming out. So this patient actually had a leak elsewhere. So that's why it's very important, especially in a patient with CSF leak, to understand where this leakage is coming from. So the problem that you will face in a patient like this, so this is a 5-year-old child. So the important thing for you to understand is that the frontal sinus is obviously not developed in this case. So you can't do a transorbital, a transnasal procedure here, because you would have to do an orbital transposition if you wanted to reach the far lateral area. So you can see the arrow mark here in the first picture. It is beyond the mid-pupillary line. So transnasal approach is going to be very tough. So what we did was we made a small incision in the eyelid, raised the periorbita and exposed the orbital rim. And the minute we elevated the periorbital, you can see CSF coming out. And this was the size of the defect. The minute we opened this, we actually switched to an endoscopic approach. There was a massive defect in the skull base, and you can see that there was a meningoencephalocele which was reduced. We did put a layer of dural substitute, Redura here, and we also put a mesh because the defect size was quite large. So we did an underlaying of this mesh to prevent any further herniation of brain into the orbit. And you can see very nicely here, this is a preoperative scan. And this is a post-operative scan, and you can see the mesh very nicely blocking this whole meningoencephalocele completely and preventing any herniation of brain. Second case that I want to share with you for a transorbital approach, here this was an ameloblasttic carcinoma. Now the thing about this lady was that she recently had children, and she's quite young. She's only 29 years old. And the problem that she had was that not a problem exactly, but the controversy that was that her vision was absolutely normal, and she had absolutely fantastic eye movements. So the whole world is now moving towards organ preservation, even in oncological surgeries. So you can see that majority of her tumor was actually along the inferomedial orbital angle, and it was extending quite anteriorly also. So the challenge that we had was that we needed to do a complete resection because we were trying to leave the eye behind. So here I have done a medial maxillectomy. You can see that the entire medial wall of maxilla is actually removed. And whatever I'm drilling, you can start to see some stalactite sort of bone spicule. And that is basically the tumor. I'm drilling along the inferomedial orbital wall and trying to remove the tumor completely. So this whole thing is actually tumor. You can see that this bone is absolutely not healthy and it's bleeding quite a lot. All this tumor is being removed in its entirety. You can see this, this whole bone is being removed along the infraorbital nerve also. And once we remove this bone in its entirety, we exposed the periorbita completely, even took a biopsy from the periorbita to check whether or not this patient had involvement of the periorbita. So I'm actually just removing the superior turbinate lower segment in order to open up the sphenoid sinus and check if there is any disease where it is extended from this area into the sphenoid. Luckily, there was no extension. It was only limited to the ethmoid, but the whole ethmoidal skull base was involved. You can see the lamina there behind. So this entire tumor is being excised even we go along the skull base. I'm using an angled scope now, and I'm actually going to use the drill very shortly along the skull base. So that's the frontal sinus being opened. So this whole area is going to be drilled, where you can see that yeah. So I'm using the drill and angled burr to drill out all the bone along the skull base to make sure that the tumor is completely resected. So after that, we actually did a conjunctival incision and went through this space and removed whatever bone was along the antero-inferior, that is the floor of the orbit, which we could not reach from the nose. We removed through the orbital incision. So this is 3 days post-surgery. You can see she has a bit of orbital edema. What you need to understand is she's developed some hypoglobus. Can you see the eyeball has actually come down because the floor of the orbit is missing. Medial wall is missing. So the eye has come down and it has come medially as well, because we have done a very radical resection of bone. But you can see her eye movements are absolutely fine. So you can also see that she has got fantastic vision. The vision is absolutely maintained, and this is the periorbita that you're seeing there. Below that periorbita, the blackish brown stuff that you're looking at is actually just surgical, which I have placed over the pterygopalatine fossa to prevent any kind of sphenopalatine artery bleeds. Okay, so you can see I'm going to do a ballotment. That is the ethmoid cavity, which is now obliterated because of the eyeball being pushed medially. So that is the periorbita. You will see that I'm going to ballot the eye, and you will see movement here. Can you see that? So this shows that there is absolutely complete resection of the tumor. There is no residual tumor left behind, and this patient is still doing fantastically well without the need for a exentration so far. So we are going to follow her up for a period of 7 years and make sure that she does not have a recurrence. It's very important for us to pick up any kind of recurrence very early on. So we do a PET scan every 6 months in these sort of cases. The next case I want to talk to you about is a Graves' disease, where you can see that both eyeballs are actually quite, popping out. And mind you, this is actually in the, the patient is actually lying down here, and you can see that there is significant exophthalmos. So the thing is that you have to understand that in such cases, the exophthalmos is so severe that the patient would not have, had any kind of, improvement by just doing a medial orbital decompression here. So we decided to do a 3-wall balanced decompression. So if you imagine, whenever you get your wheel alignment done for your car, you've got 4 wheels, right? So you want the left and the right to be aligned with each other. So similarly, whenever you're doing an orbital decompression, you can see in the picture where there is before, the eyeball is turned outward here. In fact, even this eyeball is actually turned medially. So this is not because I have, positioned my camera in that position. I've actually positioned it right above the patient's nose. But there is excess, mucopolysaccharide deposition in one side and less on the other side. So here, if you just do a medial orbital decompression, it is similar to getting wheel alignment done only for one half of your car and not getting it aligned to the other side, right? So here, what we do is we do a transorbital approach again, wherein we actually make a superior lid crease incision. One second. I want to know how to yeah, so superior lid crease incision, and you can extend this incision laterally also. So that is exactly what we did. We extended this incision laterally. That is the orbital rim there. Once you elevate the periorbita, you have to drill a small margin of the periorbita to allow your drill to enter. And what I'm drilling on is actually the lateral wall of the orbit formed by the greater wing of sphenoid and the zygoma as well. So when you start drilling, you will start to see this piece. What you are seeing here is nothing but the temporalis muscle. So be careful when you see this muscle, because this temporalis muscle, if you expose too much of it, then the problem that you're going to have is that you're going to have bobbing of the eye with every pulsation. So you shouldn't expose too much of the muscle, but you would like to leave a very thin layer of bone over that muscle, because this muscle contains a superficial temporal artery, which will cause significant amount of eye bobbing with every pulsation. Once you identify that, drill significant amount of bone all around, And you can also extend this all the way up to the orbital apex and along the inferior wall as well. Here we even did an inferior wall. We extended this incision from the superior lid crease to the lateral canthus, and we extended the same incision down into the conjunctiva. So that way, what happened was we got a C sort of incision which was made, and that way we did a 3-wall decompression. So what were the 3 walls which were decompressed? The medial wall was entirely decompressed. Yeah, one important point. Sorry, I forgot to mention this point. Before you do a transorbital approach, if you want space laterally or inferiorly, it's always a good idea to do a medial decompression by doing a transnasal approach first. How this will help you, I'll tell you. This way, you can push the eyeball into the nasal cavity so that you can get some space. So the important thing here is you don't want to compress the eyeball because there is something called as the oculocardiac reflex. In fact, in some cases, we had the oculocardiac reflex, especially in pediatric patients. Why? Because the orbit is quite small, right? So if you don't do a medial orbital decompression, you're going to land up with a very closed cavity. And when you're going to put pressure on the eyeball, there's going to be a drop or bradycardia. In a child, picking up bradycardia is a little difficult. It is not going to respond so fast. So it's important you do a medial orbital decompression and then do the transorbital approach, especially if you think that you're not going to have adequate space. Right? So I've already shown you the before and after images. Let me just go back and show you. So you can see that this gives a fantastic result. And the only incision or scar, in fact, here, because we needed a little extra space, we put an extra incision, but otherwise, the scar is actually well hidden inside of this crease, right? So you have a fantastic reduction in the exophthalmos in such cases. Okay, so now there's another interesting case that I would like to show you. This is a orbital apex hemangioma. So orbital apex is one of the most challenging cases that I've done, to be very frank. So here I've done many big tumors, but here the problem is that the tumor is only about 6 millimeters and it is sitting in a place like the orbital apex, which is surrounded by the optic nerve, the carotid artery. Basically, you can't move around too much in this narrow space. So you can see this is a T2 scan on the right side. There is no fat suppression done, but in the next image, you can see we have suppressed the fat here and the tumor gets highlighted. Can you see this? So you can see that it is sitting exactly on the optic nerve. So this is the patient. You can see that the left eye of the patient, there is a Marcus gun pupil. See, right side when you put light, it is constricting. Left side when you put light, there is dilation of this side, but constriction of the dilation of both the eyes actually. So this is actually called as a Marcus gun pupil. So possible. So the problem that he was having was that suddenly his vision started dropping actually. So his vision, why it dropped is because probably there was a bleed within this hemangioma, and that is the reason why his vision started to drop. So we had very little time to solve this problem. So we did a medial orbital wall drill out. We removed the whole medial wall, and you can see here in such a case, it makes a lot of sense to use navigation because the tumor is only 6 millimeters. So you need to have exact coordinates in X, Y, and Z axis to understand where should I open this, orbital apex. So once you identify that, open the apex and you will start to see the medial rectus muscle. So mind you, in the posterior ethmoidal space, you will not have a lot of orbital fat to protect you. So what I did was I passed a Merocell piece with a thread around the medial rectus muscle and pulled it down. And that way I got to see the tumor. You can start to see the glimpse of tumor here. Once you see the glimpse of tumor, your job is that it is going to be surrounded by fibrous tissue. You have to separate this fibrous tissue from the tumor and then peel this tumor off of the optic nerve all through the nasal cavity while holding the medial rectus muscle down. Make sure that you don't put undue pressure on the medial rectus because if it snaps, then you will have a tear in the medial rectus, giving the patient a bad, diplopia. So you can see here the tumor is just being peeled off, and here in the right image, I have peeled the tumor off of the optic nerve completely without damaging the optic nerve or its blood supply. So you can see that this tumor was completely delivered into the nasal cavity, and then I cut it with a pair of sharp scissors and then sent it for biopsy. So that is the end result of the thing. Immediately, I did not find that the vision was very much improved, but we did put him on IV steroids for 2 days post-surgery and oral steroids for 3 weeks, and his eye movement, so his vision actually improved to 6/18, and earlier it was almost just finger counting actually. And from there, he came to 6/18. He was very happy with the improvement. And so was I. At least I didn't make it worse than what it was. So that was a big, relief for us. This is another very interesting case. So here we are doing something which is beyond what skull-based surgeons would normally do. So this is a patient who's got a fibrous dysplasia, which is involving the orbital plate of frontal bone as well as the zygomatic process, the cribriform plate, the ethmoidal complex, and the lamina papyracea. Again, she has developed a Marcus Gunn pupil here. You can see the right side eye is completely involved. The optic nerve was completely involved by tumor. The cavernous carotid artery was also completely, engulfed by the tumor. So here, the reason for us to do this surgery was because one, she had exophthalmos in the right eye and she did not want that. She wanted to get rid of it. The second thing was this lady who had started developing epilepsy because of the pressure that this tumor was actually putting on the frontal lobe of her brain. In fact, she also developed some behavioral changes. She had two small children, and the husband said that ever since this problem has cropped up, she is having some behavioral changes, easy irritability, and other problems that she was facing with her children. So that was one of the main reasons why we did this procedure. So you can see that there is a mass here. This is not the tumor. This is actually, you can see that this is a mucocele because of the ethmoid sinuses being blocked. So boldly, I'm actually puncturing this mucocele because I know on a T2 MRI that this is not the tumor. So you can see that I'm actually removing the wall of the mucocele here. And once you remove the wall of the mucocele, then you actually get the tumor there. This is a very vascular tumor, in fact, fibrous tumor. So it is going to bleed quite a lot. So the challenge here is that there is so much fibrosis that for you to be able to peel this tumor off of these vital structures is where you're going to have a lot of hassle. So once the ethmoidectomy was complete, you can see now I'm at the orbital apex. I'm peeling the tumor off of the optic nerve completely. So here we don't have any fear because the patient is completely blind. The patient had no perception of light at all. So there was no hope of getting any vision back. But in such a situation, right, it makes a lot of sense to do a complete resection because you have nothing to lose here. But if you leave tumor behind, then this tumor can always grow back. She's a young lady. She's only 30 years old. It can always grow back and it can lead to another surgery. So anyways, you're not going to bring the vision back. So you might as well at least remove the tumor completely so that you can save this lady of another surgery ever again in her lifetime. So that was the main goal of surgery here. And also to decompress the brain completely so that one, her epilepsy comes down, and two, her behavioral changes also get reversed. So you can see there above the optic nerve, this white stuff that you're seeing is actually the dura of the middle cranial fossa. So this is the medial temporal lobe of the brain that you're actually peeling the tumor off of completely, right? Once we remove that, I'm using debrider in certain segments to completely remove the tumor there. So even on the optic nerve. So this is the cavernous carotid artery here. Optic nerve, that is the opticocarotid recess where I'm going in between the carotid artery and the optic nerve is the opticocarotid recess that we are going and removing this tumor completely there. From there also we have removed the tumor. You can see the white dura very nicely exposed. That is the cavernous carotid that I'm just touching with the suction. That is the vasa vasorum of the cavernous carotid actually. And that is the orbital apex and the optic nerve going into the suprasellar recess. So once this tumor was completely removed, one of the things that you have to observe was that the tumor was also going into the all the way up to the zygomatic process laterally. So I used a 70-degree scope, went anterior to the middle cranial fossa and removed this tumor completely from above the orbit. Right. So here we are crossing the optic nerve and going above and lateral to the tumor to do a complete excision. And once we did finish the excision, you can see that that space is nicely emptied out. You can see that there is no more tumor left there. This is the whole middle cranial fossa dura which is exposed. The tumor is completely removed. And once you remove this completely, then we pack this area with fat to prevent a seroma formation or a fibrous tissue adhesion between the skin and the dura here, so that there is no tension on the dura as well. So you have to keep something to interpose these two structures so that the two raw areas don't meet each other, right? So that is the entire excision of the tumor, as you can see. So we have a screenshot that is a fat being packed as an interposing material there to prevent adhesions in the future. Okay, so here you can see a screenshot next. So that was what it was looking like before. And here, this is the entire this thing. That's the roof of the orbit, dura, optic nerve, carotid, and the OCR that you can see very beautifully, completely exposed after the surgery was completely done. This is another very interesting case. This is a adenoid cystic carcinoma of the sphenoid sinus, which was involving the sphenoid and extending into the patient's right infratemporal fossa, abutting onto the middle cranial fossa dura. And you can see that there is 180-degree encasement of the internal carotid artery on both sides, and there is abutment on the basilar artery as well. So this was a challenging case because the tumor was in very close proximity to the internal carotid. So here we have a happy ending in this case. This patient also presented with blindness, where the patient only had finger counting, and we took him up for surgery immediately. And the day of surgery itself, when I met him in the ICU, he had his vision completely restored. So adenoid cystic carcinoma is notorious because it actually transmits through the nerves, right? It's got perineural spread. So you can see that the median nerve here is quite thickened on the right side. And this had to be excised completely because this thickening was going up to the petrous carotid artery also. So first thing first, you want to deal with the easy part. So here the easy part is this infratemporal fossa and segment of tumor. So the first thing is you want to ligate the IMAX to make sure that you don't have bleeding. So you get a good plane. So adenoid cystic carcinomas are well encapsulated tumors. So that way you're lucky. Surgery works very well here. Of course, you have to radiate the whole tumor bed to make sure that you don't have a recurrence. So by peeling the tumor off, after dealing with the infratemporal fossa component, I came on to the left optic nerve. You can see that the optic nerve is naked here. Tumor was peeled off of the optic nerve. That is the sella, dura of the sella. Tumor was peeled off of the sella dura. That is the median, which is thickened here. There is very unhealthy bone, as you can see, which is sitting underneath the tumor. So I opened up this median canal by drilling this bone medially and making it from a rounded structure into a C-shaped structure. And then I completely drilled out the whole canal all the way up to the petrous carotid. This is the basis sphenoid. This is the medial pterygoid plate. So the entire basis pterygoid, basis sphenoid was completely drilled out. After that, you can see that is the optic nerve, which is naked, the OCR. Now, there was a small segment of tumor which was attached to the cavernous carotid artery here. So a plane of dissection was made between the cavernous carotid artery and the tumor, and it was dissected with sharp scissors and completely cut out. And now you can see that there is no more tumor left on the right internal carotid artery. The clival dura, you can see that it is exposed and the clivus was very unhealthy. So we drilled all of this bone down and to make it look like this. So this is a preoperative scan of the patient. You can see the tumor very well here. And this is a post-operative scan of the patient. I can see that there is absolutely no tumor left behind in this patient's scan. So he does come back. So I operated this case about 2.5 years back, and even now he's not had a recurrence in this case. So another common pathology that we do find in India, especially in teenage boys, is angiofibroma. Of late, a lot of people have started doing it, but the point that I want to highlight here is that it's not a joke operating an angiofibroma. Most people might think it's very easy, but what we do see is that they do attempt it. In fact, I have a huge series of revision angiofibromas that I have, and this is one such case where you can see a massive segment of the tumor being left behind. So normally what they do is they make sure they get out the maxillary sinus component and the nasal cavity component of tumor, but they don't get this critical areas, and that is how the recurrence happens. And sometimes they're even pushed into radiation, which is not a really good thing to do, especially for a child, because the minute you radiate this child, you're actually creating aberrant DNA in the residual cells, right? So you're actually making it a fertile ground for further malignancies, right? So we think twice even before sending this child for a CT scan. So how can you just send them away for 60 grays or 65 grays of radiation, right? So you have to think about it. This is a tumor which can be completely removed if and there is, practically speaking, there is zero chance of recurrence if you've done a complete excision here. So what I'm doing here is I'm elevating the floor, the mucosa off of the nasal floor and putting a stitch to the septum so that it doesn't come in my way. I need to drill this whole, pterygoid plate because the tumor is basically like a dumbbell in the sphenopalatine pterygopalatine fossa area, and then it is coming into the infratemporal fossa. So you can see that I've already started peeling the tumor off of the fat, and that is the temporalis muscle that you're seeing. I'm peeling the tumor off of it in the infratemporal fossa and pushing it medially into the nasal cavity. I'm now separating the tumor from the bone. That is the greater wing of sphenoid. I'm separating the tumor from the greater wing of sphenoid far laterally there. And that is the temporalis muscle, which is completely exposed now. Okay. So that is the greater wing of sphenoid. That is just below the inferior orbital fissure. This is where I'm actually separating the tumor from the bone. So you can see that the orbital fat is sort of popping in. You can see if you had observed, there was some fat which was in the field, that is from the orbit actually. This is the greater palatine canal. You can actually also see the tumor is being supplied by the greater palatine canal. So you have to drill this whole canal to make sure, that is the temporalis muscle there. You have to make sure. So now we have pushed the tumor slightly medially, right? So this whole dumbbell structure has to be removed. You also saw that the tumor was extending into the opposite side basis sphenoid. So you have to remove the posterior septum, do a posterior septectomy, and peel the tumor off of the roof of the sphenoid now. So there is a small segment here which is going into the foramen rotundum, that is V2. So I actually left this bit for later because there is an artery which goes with the V2. This is an infraorbital artery also, and that might be supplying the tumor as well. So in fact, this tumor was also abutting on the median nerve, we will see later, and it was also taking blood supply from the median artery as well. So in order to create some space for the blood to seep, I just resected the nasal component of tumor and nasopharyngeal component of tumor just to create some space for blood to go into the nasopharynx. And we put a separate suction with the infant feeding tube in the nasopharynx to collect all that blood. So here you can see that I'm peeling the tumor off of the basis sphenoid, sort of pushing it up to make sure that I can get a plane of dissection there. And I'm going from the opposite side now and peeling the tumor off of the lateral wall of sphenoid and the roof of sphenoid by completing my ethmoidectomy there. And once I do that, I've entered the sphenoid sinus there, but I'm not doing I'm just packing that space to make sure that my drill does not hit the tumor, because it will cause torrential amount of bleeding here. Unless you've got a good exposure, don't meddle with the tumor beyond the sphenoid. I'll tell you why, because sometimes these tumors will get blood supply directly from the internal carotid. And imagine if you have an internal carotid bleeder in a space where you don't have good exposure, you're going to cause cerebral hypoperfusion. So that is the reason why pack that area first, get a good exposure, and then attack this cellular and sphenoidal component. Okay, that is very, very important to know. Mainly because you don't want to leave this patient with a paralysis, right? So now I'm just exposing the roof of the nasopharynx, that is the basis sphenoid and basic pterygoid is being completely exposed down to the bone. And once you do that, you know that you've done a complete tumor has been lifted up. So I'm lifting this tumor up from the floor of the sphenoid sinus. And in the floor of the sphenoid sinus, what is the structure that you will see? You will actually see the Vidian canal, right? So we should find the Vidian canal in the far lateral, just above the medial pterygoid plate. You should find the Vidian canal. Actually, just peeling the tumor off of the floor, and it says my internet connection is unstable. I hope I'm audible. Dinah, if you can hear me, or Vignesh, if you can see the video clearly.
Yes, doctor. We can
Yeah,
hear
yeah.
you.
Yes, yes, we can.
Yeah, okay. Yeah, sorry for that. So I am now just trying to isolate this tumor. So here, see, that is the Vidian canal. Can you see the Vidian nerve there? And you can also see the artery there. This is the Vidian artery which is going along the nerve. So that tumor which just got pulled out was from the lateral recess. So I'm using a coablator to just buzz this artery and stop the bleeder. So the tumor was receiving blood supply from here also. So this is the roof of the sphenoid and lateral wall of sphenoid, which has been drilled now nicely. And this is again same principle, soft dissection, volume displacement. So I'm actually packing. This is the foramen rotundum, what you're seeing here. This is the dura of the foramen rotundum. There is a small segment of tumor which is going into the foramen rotundum up to the Meckel's cave. So here I'm removing this whole bone which is over the medial wall lateral wall of the sphenoid, but which also forms the medial wall of the foramen rotundum. So why I place this merocell is because when I'm drilling, I don't want to damage what is beyond the foramen rotundum or above the foramen rotundum, which is nothing but the cavernous sinus or the carotid artery. So that is why you keep something, interpose this tissue here, or sorry, this merocell here. And now you can see this is the dura of the foramen rotundum. Now I'm pulling the tumor out of the foramen rotundum. You can see it is quite deep. Actually, these things we had identified on the scan itself before. So you need to know how to read the scan. Otherwise, see, it is so easy to leave this segment of tumor behind and cut through this and then leave this segment, and that would have grown further, right? So now you can see the one way to tell that you've done a complete tumor excision is that you should see a smooth tumor. You should not see the cut edge of a tumor. If you're seeing cut edge of tumor, that means more tumor is there behind. So here you can see this is the artery which I was telling you about, which actually gives blood supply to the tumor also. Here you have to just pack this space, make sure that there is no further bleeding. I'm just pushing some Surgicel into this space, into the foramen rotundum, and I am actually dissecting this tumor off. Here you can see, because this has been operated before, there is bone missing in the posterior wall of maxilla there. This is the pterygoid base. You can see there. And I'm actually dissecting, and you can see the muscle twitching, right? So when I'm using the coblator, you can see some muscle twitching. That means you're not on the tumor, you are on the muscle. This is the temporalis muscle, lateral pterygoid muscle, which has become fused into one. And you can see that the tumor has been completely peeled off. You can also see the IMAX there, one segment of the IMAX, which I'm just buzzing with a coblator. And I need to drill this whole bone, which is sitting in front of the temporalis muscle. So that was the last segment of tumor being peeled off, and you can see that the whole tumor is now out. So you should see that the tumor should be completely smooth pedicle. It should not be that you are seeing cut edge of tumor. If you're seeing cut edge of tumor, that means some tumor is left behind. Drill this whole bone that the tumor is attached to. I'm going to take a little bit of time to explain this angiofibroma surgery, because this is probably the most common skull-based tumor that you're going to come across, at least in India it is. So it's important for you to understand how to do these things. Oncological work, not everybody is lucky enough to get, but angiofibromas we do get quite often. So this is important for us to understand, that don't be afraid, because this tumor is abutting on the carotid. People will just leave behind that bone as it is. There are going to be microscopic remnants of tumor inside this bone. So you need to drill this bone completely till you see smooth sessile bone. Or you might even expose the cavernous carotid, but don't be afraid. That's okay. Just know where your limitations are. Of course, I wouldn't say that damage the carotid at the expense of not having a recurrence. Know your limitation, or even better, if you have a friend who's a good skull-based surgeon, at least involve them for these parts of the surgery, so that you get a complete clearance, as well as a safe. Your safety profile is much higher, right? Now you reposition this septal flap, nasal floor flap, and you can see there was zero damage to that flap, right? And you pack the whole space. I don't use merocell even in skull-based cases, because I try to make sure to the best possible extent that I get a very good hemostasis. Mucosal bleed in skull-based surgery is not a problem, but you should not leave an open artery there. So that is how you get into trouble. So this is a very, very interesting case of a foreign body inside the cavernous carotid artery. So there is a saying in Chinese that if you go to the mountain frequently enough, you will find the tiger. So this is one such case where I was met with the cavernous carotid bleed, not because of my fault, but this was a 24-year-old male with a history of road traffic accident who came 3 months after he had the road traffic accident. Now, what happened was there was a bamboo stick which penetrated through the medial canthus of his eye and got lodged in the internal carotid artery at the orbital apex. But none of this was known, because when he went to a government hospital, they just sutured it close, leaving the bamboo stick inside. They did not explore this wound, left the bamboo stick inside. So this eye is ophthalmoplegic, the right eye. There is zero vision. The cornea is completely gone. So the left eye now, because of sympathetic ophthalmitis, is starting to lose vision. So if I take him off of steroids and antibiotics, he develops, vision loss or endophthalmitis in the left eye. So my only way to reach this cavernous carotid and remove this foreign body was by a transnasal approach. You can see that once I remove the ethmoids, you will see that the foreign body is sitting in the in the orbital apex along the medial canthus of along the lamina papricia. So my job here, I know that I'm going to have a bleeder. So my job here is to expose all the sinuses to make sure that the sinuses can hold as much blood as possible, so that my nasal cavity is clear of blood, so that I have good visibility. So I'm opening the frontal, the maxillary, the ethmoids, the sphenoid, everything, to hold blood, not because I'm interested in doing sinus surgery, but because there is also some sympathetic infection here, some fungus which is sitting because of the foreign body being there for 3 months, which I need to clear. Otherwise, this patient will develop other kinds of sinus issues, right? So I'm doing it for that also, but mainly because I want the patient, I know the carotid is going to bleed and I need to hold some blood here. So you can see that this is the orbital apex. I'm removing the the periorbita, and you can also see that as soon as I move this foreign body, you're going to see that there is some amount of bleed which comes in. So this is called as the sentinel bleed. Okay. So why I'm seeing this sentinel bleed is because this is from the cavernous sinus. You can see this is a diffuse ooze in the cavernous sinus. This is not from the carotid artery because it's not pulsatile. It's not bright red. It's dark red in color. So this is from the cavernous sinus. But when I mobilize the foreign body even more, you will start to see I'm putting a marrow cell again, like I said, soft tissue, soft dissection. So I'm putting a marrow cell there. I'm pushing the foreign body into the nasal cavity. And as soon as I do that, you will see that there is a pulsatile bright red ooze. So this pulsatile bright red ooze that you're seeing now, can you see that? That is from the internal carotid artery. So for 3 months, this stick was actually lodged inside the internal carotid. So it was not creating a bleed. But now that I'm mobilizing it, there is a bleeder from the internal carotid. So what I'm doing is I'm just packing this space with some Surgicel. So I need to, this is called as convergence technique. So I'm actually packing Surgicel lateral to the foreign body as well as medial to the foreign body. And once I pack this Surgicel, now when I remove the foreign body, my only job is to push this Surgicel onto the rent. Okay, and once I push the Surgicel onto the rent, you will see that the bleeding completely stops. So this is how a carotid bleed will look to you. It's going to be absolute gusher of a bleed. You will not be able to, this is all shot in real time, by the way. So you will not see, any kind of structure physically will not be seen. But you have to use 2 suctions with some pressure on the carotid to make sure that the bleeding reduces at least. And you will be able to achieve, once you push the gauze inside, you will see that there is absolute complete reduction in bleeding. And once you remove the gauze, you will see that bleeding has completely stopped actually. So this is only half the challenge. So the rent is almost 1.5 centimeters big in the cavernous carotid. So this patient is going to have a pseudoaneurysm in a matter of minutes. So it took us about 40-45 minutes to shift him to the interventional radiology suite because there is a protocol. So once the protocol was completed, the dye was injected, and you will see that the patient actually had a pseudoaneurysm within these 45 minutes. This patient had already undergone a balloon occlusion test, so we knew for a fact that this patient does not require, you cannot do stenting. Here, the patient had good collateral flow from the opposite carotid through the circle of Willis. So we had decided that a 1.5 centimeter rent is not possible to fix. So we wanted to block this vessel to make sure that we don't have, see, this is a pseudoaneurysm. Can you see? That is the packing material there. So you can see this is the pseudoaneurysm in the cavernous siphon segment. And we did a proximal and a distal blockage. And once we did that, you can see that there is blood from this is the opposite side carotid through the circle of Willis supplying this right side of the brain as well. And here you can see this is 2 weeks after the ICA occlusion. I'm actually checking. One is speech. I'm checking all of his muscle for tone to make sure that there is no issue with his strength or tone or muscle power. And we also checked for all of his cranial nerves to make sure that he did not have any deficit. So this is one such case. Now you can see that the eye movement has come back because the stick is no longer there, but obviously I cannot bring back the vision because that eye is already gone. So I'm going to leave you with last 1 or 2 cases because I understand that it's a little late. We are already 1 hour in. So this is a very interesting case. And just for 1 second, there's a lot of, I don't know how these scratch marks have come on this video, but yeah. So here, this is again a revision angiofibroma. What I want you to pay attention is, just 1 second, I'm going to stop screen sharing and I'm going to be back to screen sharing so that all of you can see very nicely. Sorry. Yeah. So this is a 15-year-old kid. So what I want you to observe is that this guy has got a scar here. So he's already had a surgery by open approach, wherein this is an angiofibroma which was tried to be removed. Okay. So this is actually a 480-gram angiofibroma which I removed, and you can see that the tumor has come all the way up to the Meckel's cave here. Can you see this? This is you can see a beautiful medial temporal lobe here, this side, but here you can see that there is abutment. This is a V2 segment, and it has gone up to the Meckel's cave here. Okay, every single space, masticator space, infratemporal fossa, all the way up to the zygomatic process, it is full of tumor. So in such a case, what do you do? And mind you, this patient has been operated once before by open approach. So here again, I'm going against what was the old norm. That is, earlier we thought that when endoscopic surgery fails, then we do open surgery for angiofibroma. But I believe that that was a completely wrong concept, at least in my books. Why? Because with the endoscope, you're next to the tumor. With the endoscope, you can actually go behind the tumor. That is where the blood supply is coming from. So you can attack the main blood supply to the tumor, and then it's basically like, what we say in Hindi, it's a laddu. You just play with it like as if it's a ball, sweet made of sweet, So once you can attack the tumor very well. And now with the advantage that you have is that you have coablator. Earlier, a tumor like this would be a strict contraindication for endoscopic surgery, because the minute you put your scope in, you have tumor. So there's no space to work. So here I did something which is called as the divide and rule strategy. Well, you divide this tumor into multiple segments and completely remove it out. The first thing that you want to do is clear the nasal component of the tumor. That way you have space to actually allow blood to trickle into the nasopharynx, where you can put a separate suction. Now that there is flow of blood into the nasopharynx, next thing that you want to do is attack the blood supply. For that, you need to medialize the maxillary sinus component. So the residual wall of the medial wall of maxilla has to be removed completely. And once you remove that, you push the tumor into the nasal cavity and go behind the tumor. So that is what I'm doing. I'm putting a piece of gauze, pushing the tumor medially and identifying the posterior wall of maxilla. So it was a little difficult. So I removed the maxillary sinus component with a coablator. And once I removed it, it became easier for me to actually dissect this tumor out, push it medially, and identify the blood supply. So what you're looking at is a posterior wall which is cracked open. And now you will see that the infraorbital nerve also was wrapped by the tumor, which was cut off. That is the posterior wall far laterally, which I'm actually just taking the bone off to expose the temporalis muscle. So I know that if I can see the temporalis muscle, I've done a complete resection. That's the infraorbital nerve, which was completely engrossed by the tumor. So I just resected it out. So now you can see that is the IMAX. So that is one of the branches of the IMAX which is supplying the tumor there. So I used a coablator and actually cut through this IMAX to make sure that I don't have any bleeders or I don't have a blood supply to this component of the tumor. And once I did that, this tumor became very easy to play with. That is the temporalis. You can see that the vertical fibers of the temporalis are coming into view there. And once you see this, you know that you've done complete tumor resection. And after resecting this whole segment, that is the maxillary sinus and infratemporal fossa component, you can see it was quite massive. I could not remove it through the nose in one piece. So I actually cut this into 3 pieces. Now, because it is completely devascularized, there is no need to use coablator and waste the wand, but you can actually just use scissors. You can see that it just doesn't bleed. When you devascularize the tumor, remove this tumor completely, you can see that it was massive pieces of tumor which was being removed. Quite tough to deliver through the nasal cavity, but with a little bit of wiggling, we managed to get it. That is tumor-free bed. That is the temporalis muscle. That is the masticator space that you can see there. And now that is the cavernous sinus component of the tumor. This segment of tumor has been pulled out of the cavernous sinus there. And now you're seeing that I'm delivering this segment of tumor, which was anterior to the pterygoid plates. So that is the peritubal space. So this is the medial pterygoid plate. I've gone behind the medial pterygoid plate into the peritubal space, and I'm pushing a piece of gauze there. So you will see that these branches are actually supplied by the ascending pharyngeal artery. So you have to pack this space and make sure that there is no bleeding. So just deliver this whole component out completely. Now we are coming to the cellar component. So like I said, I always like to deal with the the sphenoid component in the end, because you might have branches which are coming from the ICA here. So you should not take them lightly, because you might think that it's just bleeding because it's a tumor, but the patient is going to be, losing blood from the internal carotid, and that is not safe. So there is a part of the tumor which is going inside the foramen rotundum, which I am going to deal with later. So this is all the clivus and the posterior wall of the sphenoid sinus. I'm peeling the tumor off of it completely, and this whole segment of tumor is out now. And you can see that I'm just, wherever I'm peeling tumor off, I'm packing with gauze to make sure that I don't have a lot of bleed, because this child is quite young, so I can't afford to lose a lot of blood, right? So this is a cribriform bone. So this is the optic nerve. Can you see this is the patient's left optic nerve? So this is the area of the cavernous carotid below the optic nerve, and I'm drilling all of this bone without any fear. You have to drill all of this bone completely to make sure that this tumor does not come back. So don't hesitate to drill this bone. Why? Because of course, if you're trained well, then do it, but make sure that you drill all of this cribriform bone till you see healthy bone. So this is the V2 segment of tumor there, and you can see that it's pulsating with the brain pulsation. So now your job is to go 360-degree around this tumor. That is the medial temporal lobe of the brain there. And you can see that this tumor is quite densely adherent to the brain. So you have to make sure you don't damage the dura there, but at the same time, you have to make sure that you get a very good clearance of tumor. So this last segment of tumor, I used a J curette to sort of peel this tumor off of the medial temporal lobe dura. And once that is done, again, don't hesitate to drill all of this medial pterygoid, basic pterygoid bone, and make sure that the dura is flat so that you can put some dural substitute in that area. And once again, just pay attention to this, whatever segment that of bone that the tumor was touching, drill all of it and clear this tumor completely. And exposed dura has to be covered with a second layer of dura as well, to make sure that you don't have a meningoencephalocele or anything in the future. So this is what the patient looks like as of now. So you can see that you can actually, I'm showing you the same patient because you can see that, you can see the scar here, right? This is the same patient, this is the scar. And once you go in, you will see that there is absolutely zero tumor left behind here. You can see that is the whole nasopharynx. There is so much fibrous tissue which is nicely formed. And these are the scans before and after. And you can see that there is absolutely complete clearance of tumor. We have not left behind any tumor in any of the spaces. So this is quite challenging to do. And the last case that I'm going to leave you with is this one case where we are, I'm going to show you this scan. This is an extremely rare tumor. This is basically called as a glomangiopericytoma. So this is the only tumor that I had to stage in my whole life, right? I've been doing skull-based work for the last 8 years of my life, but this is the only tumor I staged in my whole life. Why? Because, so this is an extremely vascular tumor. This is the 6th tumor in the world reported to be a glomangiopericytoma. So imagine if a glomus tumor and a hemangiopericytoma had a baby, that would be a glomangiopericytoma, right? And this tumor is going into the masticator and parapharyngeal space. You can see this is the component which is the problem. This is the pharyngeal, the pharynx here. You can see here, this is the pharynx. Can you see? So this is the pharynx here, and this is the parapharyngeal space. It's coming all the way down to the parapharyngeal space. And this is probably, I did a literature search, and probably either the first case or the second case where we have done a transnasal endoscopic approach to the parapharyngeal space. Normally what they do is they would make a cervical incision in the neck, or they would do a transoral approach. But here, my logic was simple. If the tumor can go to the parapharyngeal space from the nose, then I think even we can go to the parapharyngeal space from the nose. Why? Because this is a malignancy. My logic is core out the tumor from inside rather than opening the tumor from the outside and giving it more space to travel, right? So this is a malignancy, and mind you, this has been operated 2 times before and failed. So what I have to do differently is I have to make sure that this tumor is completely excised, because patient has come for a complete tumor excision. So if you're in doubt that you're not able to get this parapharyngeal space component completely, use your head and neck colleague to do a complete excision by a cervical incision. But don't leave this tumor behind. Why? Because this patient has come specifically to get rid of this tumor. So the approach is not important. But why I'm showing you this approach is because it can be done. That is the point that I'm trying to just make here. And can it be done to the extent where you don't have a tumor recurrence? Yes, I will show you with evidence here. So once we removed the component of tumor, expose the posterior wall maxilla, again, majority of these tumors are going to get that blood supply from IMAX. So ligate the IMAX. So you can see the tumor here. and the tumor was actually attached to the medial temporal lobe of the dura, which was completely peeled off of the medial temporal lobe dura, and the infratemporal fossa fat, it was attached to the fat. So you have to go one level higher, remove all of the fat and expose the temporalis muscle. So the temporalis muscle looks uninvolved by the tumor. So once this whole tumor was completely excised, cellular component was removed, then we come to the peritubal parapharyngeal mucosal space, which is medial to the medial pterygoid plate. So normally this space will not be open because there was widening of the space by the tumor. We could go inside. So you can see here, this bone which you're seeing next to the debrider is actually the medial pterygoid plate. I just drilled all of that out and completely removed the tumor in this space, excised the eustachian tube, and I went along the eustachian, lateral to the eustachian tube. And when you use a 70-degree scope and a 60 rad debrider plate in this space, what you're seeing here between 11 o'clock to 9 o'clock is actually, or maybe 7 o'clock to 11 o'clock is actually superior constrictor muscle. And I'm lateral to the superior constrictor muscle, clearing the tumor. You can see the tumor here very nicely. This is tumor. Once you clear that out, you can see that when you go on clearing, you can see this is all muscle, which is normal. And this is the tumor, which is left behind. And once you clear it completely, there is zero tumor left behind. And this can be proven by a PET scan. So here you see that this is taken probably about, I think about a month or so after the surgery. And you can see that there is zero tumor residual in this space compared to what it was before. There is no tumor being left behind here. Okay. And this is a small video that I would like to show on how you can clear the tumor there. See, that is all tumor that is being cleared there. And just keep, point your blade away from the muscle and keep removing the tumor completely as you go. And you can actually make sure that the tumor is completely removed. You can even dilate the space by putting some gauze in to make sure that you don't have any, undue bleeding or anything of that sort. This is another case where we had to go intracranial. This is the last case that I'll probably discuss. So the usual stuff, tumor was peeled off of the cavernous sinus and all that. And then this is the dura of the anterior cranial fossa that I'm actually opening with a sickle knife. And now I'm using a ring curette to fish out all of the tumor which has gone intracranial. So I just want to show you the scan. You can see the large component of the tumor has gone intracranial here. Okay. And once we remove the tumor, what you will see, this is the falx cerebri here, which is basically we're in the left anterior cranial cavity. This is the basifrontal lobe of the brain. And here I want you to observe two things. One is, you can see very beautifully this color of brain, which is yellow, and this color of tumor, which is gray. So this is called as tumor brain interface. So you should know how much tumor, how much to remove, right? Because sometimes you might go in and get a little confused. If you're in doubt, just wash this area so that you can clear off all the blood clots, and then you'll get a very clear idea as to what is normal brain and what is abnormal tissue. It's important because you want to leave as much normal brain as possible. See, this is all normal brain. So once we remove the tumor in its entirety, we could see that a large part of the brain actually shrunk down because so much tissue was being occupied by the brain, by the tumor, right? And you can see the falx here, and this is the anterior, posterior table of the frontal sinus, or anterior margin of the anterior cranial fossa here. And this tumor was completely excised. So I'm not going to show you another JNA. This was again done similar approach, but yeah, I think it's a little late, so we will probably stop here. We always have a lot more cases to discuss. I would like to inform you that we do have, our cadaver course coming up, which is going to happen. Vignesh, can you please announce the dates for the course?
Yes, doctor.
So we do run a cadaver course where we teach all of these aspects. We teach even transorbital approach. I teach orbital apex approach. I teach everything on this course. We have absolutely fresh cadavers, which we do here. I think some of the people who've attended this webinar have all are testament to the fact that they have attended our course, and they've gone back to their respective countries, and they're already doing these kind of surgeries as well. I do keep getting queries from them as to how to tackle this, and I do help them out as well. So once we it's a long journey. And I understand that skull-based surgery, it's something like, see, there is a saying that never try to fly without running, and never try to run without walking, never try to walk without crawling, right? So we have to go through this whole process. Unfortunately, if you are interested and you're here today to attend this webinar, it's because you love this subject, you are passionate about it. But believe me, it's going to take a very long time for you to be able to do surgeries which are going to blow everyone's mind. Don't expect that I'm going to, tomorrow only I'm going to start doing angiofibromas left, right, center. You're going to have to take baby steps. You're going to have to do amazing sinus surgery first and then progress to skull base. The least you should be able to do to even think about entering skull base surgery is CSF leak repair. If you can't do CSF leak repair, don't even attempt to do skull base surgery. I'm not saying this because I'm afraid of the competition. I'm saying this because the most common complication in skull base surgery is a CSF leak. And if you cannot handle that, then you're not eligible to do skull base surgery. So please make sure that you follow these. We are going to talk in a lot more detail on how to improve, what should be the approach, what instrumentation to do, and all that when we do our cadaver course. Even if you don't want to dissect, or if you feel that it's a little expensive, or if you want to try it out, do come as an observer. You will learn a lot by just being an observer. In fact, Dr. Diana has been an observer on our course many times, and now she also has been a dissector after watching, so many times she would want to dissect, because watching is completely different from doing it on your own. So this is going to be a fantastic course, and all of you are most welcome. I think the dates are 15th and 16th of July, if I'm not wrong.
It's on 17th and 18th of July.
Okay, yeah, 17th and 18th of July are the dates, and please make time. And if you want, you can get in touch with Sumana, or they will probably follow up with by sending you a link to the cadaver course as well. And we've got the whole instrument set. So we have ordered 6 sets of instruments, the whole skull base set. Not like what happens in other courses where you only have one forceps or one elevator or whatever. We have the whole set, including pituitary forceps, everything, the whole rhinology set, because we have purchased it. That is the kind of passion that we have towards teaching all of you as well. So thank you so much for attending this webinar, and I'm more than happy to take any questions if we have any now.
There's one question posted in the chat box.
Okay.
What are the prerequisites of orbit decompression in Graves' disease?
Prerequisites. So see, when you are saying prerequisite sorry, what is the question? 1 second.
Prerequisites of orbital decompression in Graves' disease.
So when you say prerequisites, is the person who asked the question here? If you are, then you can unmute yourself and kindly talk to me, or probably send a chat message. See, prerequisite means when do you do it, or if you are talking about when we should do orbital decompression. So the first thing that you need to understand is Graves' disease is more of a medical issue also. So when you put the patient on beta blockers and steroids, and they usually, that is the ophthalmologist domain. Usually they will put the patient on this medication for at least about a month or so, and they will assess whether the mucopolysaccharidosis, which is happening in these cases, is going down. If the inflammation and mucopolysaccharide deposition which has happened goes down, then you don't need to operate. So you should not have good amount of scleral show. Like what you saw in my case was that there was so much scleral show, right? That should not be there. Second thing, the patient should not have exposure keratitis. If any of these issues are happening, or cosmetically, if you're seeing that the eye is looking bulged, then definitely, so there is a grading for exophthalmos also. If it is anything beyond grade 2, then yeah, you need to decompress. That is, even after medical treatment has been given and still grade 2 exophthalmos is there, then you need to decompress the eye. Any other questions?
Hello.
Yeah.
Hi, sir. This is Dr. Pujita.
Yes.
So, for post-traumatic cases with optic nerve injury, so until when can we try optic nerve decompression? Do you do VEP for all the patients?
So I'll tell you. So what happens when we get a case of post-traumatic, whenever I get called for an optic nerve decompression, so
Yes,
it's
sir.
one of the two scenarios. One, patient has recently had an accident, and patient has rapidly lost vision. Okay, they go down to almost finger counting or no perception of light almost immediately. In such a case, you want to do two things. One, you should do a CT scan. Okay. And
Okay.
second thing, you should do a MR angio, especially of the ICA, that too ophthalmic segment. Okay. So
Okay.
what you're trying to do is, when you're doing a CT scan, you want to assess if this patient has got a bone chip which is sitting on the optic nerve.
Okay,
If
sir.
that is there, then there is no point in giving the patient steroid, because that bone chip is not going to move on its own.
Yes.
You have to physically go and move it out. As simple as that. So that is your primary indication there only. Like you take it away straight for surgery. Second thing is that if there is any compression in the canalicular segment of the optic nerve, because of all the segments of optic nerve, canalicular segment is the one where the optic nerve is passing through canal, where it occupies almost 80 to 90% of the canal. And mind you, optic nerve is actually not a nerve. It is an extension of the brain itself. So it comes with three coverings, pia, arachnoid, and dura also. So the pial vessels which are there, whenever there's an injury, if the canalicular segment moves, right, then
Yes,
the
sir.
pial vessels get shared. That is torn. They get torn. So there is going to be bleeding inside of the optic canal, the canalicular segment, which will cause compression of that optic nerve. And
So
if
this
that
can
is
happen
causing,
with this blunt trauma also.
absolutely, it can happen with blunt trauma, because ultimately, see, the force which gets transferred, right, it causes the
Yes.
crack. So you
Okay.
might have seen in movies, they show you Hulk will punch a wall and the crack transfers through the whole wall. The same thing happens even in blunt trauma. So if these two things are there, where you have canalicular segment hypoperfusion, okay,
Okay.
or if you have a bone chip which is impinging on the optic nerve, straight away take the patient for surgery, because your surgery will work wonders on this patient. You can actually totally reverse the vision loss. Okay.
Okay.
Now coming to the second scenario where they have given steroids. Let us say it is neither of these. Okay.
Yes, sir.
And the ophthalmologist has tried steroids for about 3 days, 4 days. You are not seeing any improvement, zero improvement.
Okay.
Or if you are seeing worsening of vision, then
Yes, sir.
it becomes an indication for surgery.
Okay.
In the latter situation, which I just mentioned to you, you have to give the patient a guarded prognosis, because steroids have not worked.
Okay.
In trained hands, if you do a risk benefit analysis, in trained hands, the risk is going to be very low when you do optic nerve decompression. But the benefit, if you get something out of it, is going to be tremendous, because it's life changing for this patient, right?
Yes,
So when
sir.
you have to do a risk benefit analysis, counsel the patient that you may or may not get any vision. In fact, I even go to the extent of saying that despite my surgery, you might continue to lose vision, but this is our last hope. If you're happy to do it, I'll do it for you. If you don't want to take the chance, then I will leave it. That's all. Because
Okay.
you're having rapidly progressive vision loss. That is why you've been referred to me. The doctor has given you steroids. Still, you're not improving. In fact, you're deteriorating. That is the reason why you're here. So you have to explain this and take it up. That's all.
Okay. Yes, sir.
Is that clear?
Yes, sir.
Okay.
Thank you.
Dr. Rudra Prasad, I think he has joined us all the way from UK. Thank you so much, sir. He sent out a message saying it's a great presentation and there was so much to learn. Thank you so much for
Thank you,
your
Gaurav.
support. Yeah, thank you so much, sir. If there are any questions, we'll take it. Otherwise, we can close the presentation. Or even Dr. Chandrasekhar has joined us from Maldives.
Yes, Gaurav, excellent presentation.
Thank you, sir. Thank you so much.
Terrific cases. Good to see you.
Thank you, sir. Thank you so much.
Do we have any more questions?
Okay. So if we don't have any questions, then thank you so much for attending. And there's one question from Jyoti Ranjan. If carotid rupture occurs, what should we do? So I think we showed that in one of the cases. So I'll just talk a little bit about carotid rupture. So if you're, what is the risk for carotid rupture is something that you have to know before you go into the surgery. So the highest risk is actually, and this has been done, there has been documentation done here, is with the craniopharyngioma. Now the risk is maximum in the cavernous segment of the carotid artery. Why? Because if you take the cavernous sinus, it's an inverted pyramid which has 5 sides. Okay, so the base is above, that is towards the brain. The apex, which comes and joins at V2, that is foramen rotundum, through which V2 segment of trigeminal nerve goes, that is the apex. So it ends at the V2 segment. Now the medial, all these walls, medial wall, lateral wall, posterior wall, anterior wall, and roof, they all are basically dura. Of all these walls, the medial wall is the only one which is single layered. All others are double layered, which is quite unfortunate because tumors which start in the sella, which start in the ethmoid sinus, which start in the sphenoid sinus, they all penetrate easily through the medial wall. And that is how you have cavernous sinus involvement actually. If a tumor is occupying more than one segment of the carotid, like you might see the tumor is extending into the parapharyngeal carotid also, and it is extending in the cavernous carotid also, the supraclinoid segment of carotid also involved by the tumor. So there are 3 segments involved. So obviously the risk is going to be 3 times higher because whenever you're dissecting the tumor of carotid, that is when the risk is high. So this is one risk factor. Elderly patients, the risk factor is again quite high. Why? Because not only because of the carotid going into spasm in these patients, but also because they're going to have some plaques inside the carotid, which will lead to cerebral hypoperfusion. Craniopharyngioma tumors, malignancies, these are all high risk factors. So when you identify such high risk cases, you need to preemptively talk to your interventional radiologist. So once you talk to your interventional radiologist, then you have to come up with a balloon occlusion test to be done. Because if you do damage the carotid, what is going to be the plan? So don't do skull base surgery in a center where there is no interventional radiology. So that is the reason why most of my cases, whenever I feel that there is a risk for carotid, I do it in HCG hospital, which is, we have got a fantastic interventional radiologist, Dr. Indu Shekhar, who helps me out a lot. So one way to operate is if there is flow from the opposite side, then you can actually pass a catheter into the internal carotid, keep before the bifurcation, stay before the bifurcation, don't inflate the catheter. The minute you have an injury, you go into the internal carotid, the interventional radiologist will be with you only in OT. Because you're going transfemoral, they will push the catheter into the ICA and they will inflate the catheter. That time, you're not going to have a breathe. So that will give you time to either you can pack or you can stitch the rent or whatever it is you want to do, you can do. Now, this can be done very specifically only in cases where you have cross circulation from the opposite side, because if you block the ICA on this side, there's going to be cerebral hypoperfusion. What if you don't have perfusion from the opposite side? In those situations, you're screwed because you will have to do you have to use something which is called as a flow diverter. Now, flow diverter is a very expensive ordeal. The diverter itself will cost you around 6 lakhs, not to mention the surgery, which will go on for about 18 hours, and the patient has to be on blood thinners for the rest of their life. It is not always successful because the diverter itself can also get thrombosed. So these are some of the risks. So the first thing you need to do when you have a carotid bleed is pack, inform your interventional radiologist immediately that I've got a bleed. If you have preemptively done a balloon occlusion test, you're lucky because then you can ligate the vessel immediately. If you're not, then you're in a soup because it can become a medical legal problem for you. So the next question is there chance of post-op diplopia and strabismus whenever removing tumor involving medial and inferior orbital wall in maxillectomy approach? And how to do reconstruction in this orbital wall? We have to do it in same setting or in a second stage surgery? Okay, this is a very nice question actually. So whenever you do a medial wall removal, right, the orbit, if you are not pushing the orbit too much into the nasal cavity, then the chance of diplopia is actually quite less. But if you do a floor of orbit removal, the problem is that you have removed 2 walls. In that case, the eye goes down and inward, that is towards the septum. So in the lower gaze, they are going to have diplopia. This is common actually. And we do explain to the patient, especially if the tumor is like that lady who I told you, hypoglobus with medial wall removal. We had already told her that she's going to have diplopia. Now, the question which you asked me, the second part is quite interesting because you want to do reconstruction in the same setting or in second stage. If it is a malignancy, I would do a second stage reconstruction. Why? Because I want to make sure that I don't have any residual tumor. I would wait at least for 2 years with a clean PET scan for all those 2 years. before I even consider reconstruction. Why? Because if you have some residual tumor there, your implant will have to come out again. Second problem is, whenever you're putting a implant, it is going to be only for the floor of orbit. There is no implant which you can put for medial wall of orbit. You can put a custom made titanium mesh which is made by 3D printing. So to put that, you need to have the pterygoid plates, posterior wall, maxilla, and lateral wall should be intact, because you need to screw it there. And how do? You do a sublabial Caldwell-Lock approach, put the implant, and then you have to come out. I've done some cases with my oculoplastic surgeon, my friend, who is also faculty on this course. His name is Dr. Raguraj Hegde. In fact, we will be showing transorbital approaches together. So second stage is always better if the biopsy comes out as a, I mean, of course, you will know what you're dealing with before you go in for surgery, unless it's a vascular tumor. If it's a benign tumor, then you might as well go in primary stage only and fix it off. But if it is malignancy, just wait for 2 years so that you know that you've got a clean chip. You can put a bone graft also, but the problem is to customize it to your requirement is going to be tough. With a titanium mesh, nowadays we can get a 3D printed template, and they will design the titanium mesh to the exact same dimensions as the bone loss. So that way your fitting will be much better. But of course, you cannot leave a titanium mesh exposed. So if you are putting in a titanium mesh, you need to cover that mesh with some sort of a muscle flap also. That is something that you need to understand. Even if you're putting bone graft also, you will still need to put a muscle flap. So you can either use a temporalis muscle flap, which is rotated, or you can use a free flap, like, you can take anterolateral thigh flap or radial forearm free flap, one of these, and anastomose it to your external carotid branch. This your reconstructive surgeon will do it for you. And we do have some cases where we have done this very successfully, actually. I hope, Dr. Lakshmi Bhatt, that answers your question.
Yes, sir. I got, sir. Thank you so much, sir.
Yeah. Sorry, Lakshit Bhatt. I'm so sorry.
Yes, sir. It's okay, sir. Thank you so much.
Yeah. So all in all, thank you guys. Thank you so much for joining us. And I think we will end the lecture here. It's already almost 8:30. So thank you so much for joining in. And I hope that I will see some of you at least at the Cadabook course. Take care, guys. Over
thank
to
you so much.
Vignesh. Yeah.
Thank you.
Thank you so much, Dr. Gaurav, for your exuberant presentation. We are all really motivated, we are challenged, we are inspired looking at your extraordinary work and presentation. It was really a pleasure to have you. I also would like to thank all the participants for taking your time to join us today. Thank you so much.
Thank you, sir. Thank you.